Hello, I'm Peter Kelly from Dublin, and I thought I'd tell you this morning about the Irish National Stroke Programme. The Stroke Programme was set up as a collaboration between health administrators and stroke clinicians in Ireland in 2010, and the aim was to improve stroke services in Ireland, which had been suboptimal in the previous 20 years. The key concept behind the Stroke Programme was that of collaboration. I've already mentioned the collaboration between clinicians and health administrators, but there was also a collaboration at several other levels, which was really key to the success of the programme. The first area I would say is that there was collaboration between specialties. So I'm a vascular neurologist, but much of stroke care in Ireland, in addition to being delivered by neurology, is also delivered by our colleagues in geriatric medicine. So the programme was jointly led by myself and a colleague who is a specialist in geriatric medicine, Professor Joe Harbison, for the first phase. There was also strong collaboration between health professionals and patients via our patient organisations and the Irish Heart Foundation, and across other health professional specialties such as nursing and allied health professionals. And as mentioned, strong collaboration, which is really essential between the professional community and health managers. To prepare for the programme, several key enablers had been put in place in the years prior to its starting. So the first was, over several years, we had gradually developed this culture of collaboration and really formed a common goal between the medical community in particular across multiple different hospitals. The second thing was that we had a plan. In the years between 2007 and 2010, prior to the programme beginning, we had been working with government to develop a national stroke strategy. So this was formally adopted by government in 2010 and launched, and the programme was expressly designed to deliver this plan that had been agreed. The third issue was funding. Funding was very difficult when we started the National Stroke Programme because we were living through the economic crash, which began in Ireland around 2009 and persisted really till 2013, 2014. So there was no large pot of additional money there to fund the programme. However, after carefully discussing the whole matter of funding with our partners in government, a system was devised whereby funding would be made available to hospitals from funding that was already in the overall health budget, on condition that they engage with certain key aspects which were part of the national programme. So the first phase of the programme ended in 2015. Myself and Joe Harbison then were replaced by our colleague Ronan Collins, who has very ably led the programme since then. But at the end of the first phase of the programme, some of the key metrics were as follows. So when we began in 2010, less than 50% of the Irish population had access to stroke thrombolysis. This had improved to 100% of the population by the end of 2015. Secondly, all stroke hospitals which accepted acute stroke patients had stroke units by the time the first phase of the programme ended. And this coincided with the appointment of, roughly speaking, about 70 to 80 new staff across all disciplines, but in a very targeted way to support these units and the existing units. These changes coincided with big reductions in mortality and nursing home admissions for patients with stroke over this 5-year period. So mortality dropped by about 20%, as did discharge from acute hospitals to nursing homes. So these are very meaningful and real improvements in metrics for our stroke patients at a national level and in a relatively short period of time. So for me, the key lesson for the Irish National Programme is that it is possible to improve stroke care across an entire population within a relatively short period of time and with a modest budget to do it. But it's really essential that there's a team approach taken between the clinicians and between the health administrators and also patient groups and voluntary societies. It's also essential that there's a plan, there's a blueprint to guide everybody along the way so that everybody is clear what we're trying to achieve. And finally, it's very important that the whole program is very well managed. And in my opinion, it's really key that clinicians are in a position of leadership for such programs, but working very closely with non-clinical health managers. So that's the experience from Ireland. I hope that has been helpful to everybody, and it's been an absolute pleasure to talk with you this morning. Take care. Bye-bye.